All right, everyone. Hey, this is AJ. I want to really apologize again for the mix-up in the timings. I took complete responsibility for that. I looked at the future invites for our last two sessions, and they should be completely okay for 11 a.m. Central for the last two sessions. So other than that, I want to give it off to Andy, and we'll get started.
Great. Good morning, or I guess afternoon for folks on the East Coast. And today we're going to be talking through the two final skill sets we want to cover in the session, and then also introduce our next session, which is going to be largely focused on discussing various different payment models and the financial considerations, essentially wrapping these skills kind of around real-life payment models out there. So we're going to save some time at the end to introduce that concept. That will replace your homework for next week. For the next 2 weeks. Instead, you'll be working with your group to kind of talk through that case study. And we look forward to introducing you to that information. We're going to move ahead and just remind you that we have two more sessions after today. And both of them will occur at 11 o'clock Central Time. Next week, as I mentioned, in 2 weeks, we will be reviewing the case study. It's going to be a largely interactive conversation. We really hope that you folks bring your A game when it comes to kind of interacting with us. And then the final week, we're going to ask you guys to do just a little bit of report out. Many of you have already signed up for and or attended a very brief conversation with our team, just to make sure that you understand the task and the work at hand. We hope that you guys don't find it to be too burdensome an exercise, but we really wanted to make sure that coming out of this learning opportunity, that you had an opportunity to kind of reflect back on your specific situation and how this work impacts your organization. I want to quickly take a look. We asked you to answer a couple of basic questions as your homework assignment over the last 2 weeks. And we wanted to talk a little bit about what you saw as some of the things that would help you in your ability, improve your ability to forecast financial outcomes. And not surprising, some of the results we got are pretty typical. The first would be access to data. And we'll talk a little bit today about managing finances under a value-based reimbursement methodology, and data is absolutely critical to doing that. The second was around better risk calculation capacity, and today you're going to see how risk essentially gets factored into a variety of different budgeting formulas, because ultimately value-based reimbursement methodologies typically ask us to reallocate or allocate differently the resources that we have at our disposal for caring for patients. Others said tools and templates to help forecast based on current contracts and potential payment arrangements. I think you will see some of that today, and I think we'll be talking largely about this in the case study that we will visit together next session. And then some guidance on rulemaking, and I think this is a particularly interesting subject for folks, because certainly it's been our experience that the processes that go into developing state-level plans, whether it's a state plan amendment, whether it's an 1115 waiver, are very complicated, and that safety net providers in particular really do need to kind of stay on top of that, because it does impact largely the population of patients that we serve. We asked you folks what percentage of you had formed a leadership group specifically to oversee clinical strategies that lead to positive financial outcomes under value-based payments. I'm going to talk today about managing, what it kind of feels like to live in a value-based reimbursement world, and then Amanda's going to talk specifically about budgeting, what budget line items should you expect, and then the just really kind of rough approaches to how to put together a budget. But when we talk about managing, I think the theme you're going to continually hear is that it's going to take an interdisciplinary leadership approach in order to in order to make the critical decisions that are going to lead to positive financial outcomes. And really, it's been our experience, the only way to do that successfully is to formalize that interdisciplinary leadership group and really look at the two sides of the equation, the clinical strategies that are going to lead to financial outcomes. And we're going to talk about those as well as a couple of other important strategies today. So this is an area where we'd ask the group to think about starting to put together that team. It looks like about a third of you, or exactly a third of you, have formed that group. And again, in our experience, the most successful organizations are the ones that really have a formal approach to how they do that work together. And we'll talk a little bit about that today. We also ask you to talk about your ability to report and review clinical data and the connection it has to your providers or even your expanded care team's compensation. And the good news is most of you have the ability to report on these types of outcomes. Two organizations responded that they're still working on incorporating that into their processes. But, I think everyone's understood the importance of accessing and using clinical data. Most indicated that they formalized those reports into some kind of dashboard or standard report that can then be shared more broadly through the organization and specifically with providers. Some provided tools to allow providers to go in and check on their own progress so they could actually work with their own panel of patients or their own data and information. But none of the organizations indicated that they had developed advanced models for compensation under new value-based reimbursement models. And that's an area we'll touch on today. And it's certainly a very hot topic and one in which I don't know that any true best practices have emerged, but we'll talk about some and sort of how to think about that challenge and that problem. So as we mentioned, today's conversation is going to focus on three areas: managing finances under value-based reimbursement, effective budgeting for value-based reimbursement, and a discussion of the case study, which will make up next session's content. So as we talk about managing, I'm going to address 5 specific areas that we see successful organizations addressing as they move into value-based reimbursement. The first is around assessing and improving the revenue cycle. The second is building the right management systems and processes. The third is developing appropriate clinical programming that's sensitive to the financial realities of your contracts. The fourth is evaluating and implementing new compensation models. And the fifth is predicting the impact on cash flow. And in each of these areas, value-based reimbursement provides some opportunities and some challenges. So we're going to explore a little bit of each. One of the key strategies that we've recommended all organizations undertake, really as they see that value-based reimbursement may be inevitable in their community or in their region, is to just better understand their current financial performance. And there's a lot of reasons why we feel this is a worthwhile strategy. First, it may identify opportunities for improvement that can help fund some of these activities. The very first session, we asked you in your homework to talk about whether you felt you had the capital necessary to make the type of investments that you'll need to make in order to be competitive in a value-based reimbursement world. And there was some concern that that was a significant barrier. And we've seen organizations that have really looked at their existing revenue cycle as a way of closing some of those gaps. It's also common at this time that you have either the opportunity or will be faced with the threat of a shifting payer mix. In some markets, certainly with Medicaid expansion, you'll see a large potential increase in your ability to generate cash. If suddenly a large percent of your uninsured population becomes Medicaid and are being paid in a very different way to your organization, that could lead to new cash opportunities. In other cases, you may see some direct competition for your patients that could lead to unintended shifts in your payer mix. So you may actually see a net decrease in insured or uninsured patients. All of that to us suggests a need to look at the revenue cycle, make sure it's functioning effectively, and make sure there's not opportunity being left on the table. It's challenging, and we've, having represented a lot of safety net providers in contracted discussions, it can be really challenging to seek enhanced compensation if you're not seen as a good steward of existing financial resources. So if the organization is not good at drawing down money based on existing contracts, if your organization has a somewhat of a challenge in terms of things like very high denial rates or late claim submissions, I think, in those cases, it can be really detrimental to asking for additional resources. So making yourself as good a partner to your payers is certainly a strategy that actually helps smooth out those negotiations and those discussions. You're going to probably need to implement some new strategies for dealing self-pay patients under high deductible plans. So if you have broad exposure to marketplace plans that have high deductibles, in some cases those patients will look more or less like self-pay patients. And the revenue cycle challenge essentially associated with those high deductible plans could represent a financial threat to your organization. One that I like talking about because I think it actually provides some upside is that new payment models occasionally and sometimes often will offer new opportunities to directly bill for services that are tied to performance against value-based reimbursement models. An example is most states now having some clarity on the billing of telehealth services under Medicaid. And so it's always a good idea to be looking at our charge master and understanding, are there things out there that we theoretically could be billing that we aren't billing today? You're going to need some new capacity and skill to bill under value-based reimbursement. So again, shoring up your billing now, shoring up your processes now makes a lot of sense so that as you start to layer in new processes, you're building upon good practices of the old. And credentialing and coding issues that you experience now really can impact and negatively affect the attribution and allocation of financials down the road. So if you're not coding and billing correctly now, that could actually impact which patients get assigned to you later, which impacts your total potential, if you will, under value-based reimbursement. So for a lot of reasons, getting started financially in these models, we really think is starting by getting back to basics around the revenue cycle. So I'm just going to briefly talk about a couple of things that we've recommended that groups typically do. On the actual revenue cycle performance side, it's really important to get an understanding of how well you're turning charges into cash across a variety of different payers. This way, should you experience shifts in payer mix tied to new reimbursement models or Medicaid expansion or managed care expansion, that you'll have an understanding of how that will impact your business. Again, doing that by plan, by payer, or even, we think it's even important to be looking at that by plan, particularly in marketplace plans that have a lot of variation, is important. Understanding denial rates, looking at coding levels both in the ICD-10 and CPT coding arena to make sure that you're describing to your payers all the work that you're doing with these patients, as well as all of the illness or disease essentially that's presenting at your organization, is critical. And of course, days cash on hand, which is something that most organizations going into value-based reimbursement will want to shore up to the extent possible, and achieving benchmarks there and even exceeding benchmarks there, because you will be looking at, as we'll talk about, you will be looking at situations where you'll want to have some additional cash reserves due to some of the timing challenges of how value-based reimbursements work. On the charge master side, which should be a part of this assessment, we want to be looking at essentially state and payer policies on billing a variety of different things, telehealth services being one. Another would be same-day billing. I know the FQHCs have struggled with getting payers to pay for same-day visits with mental health or behavioral health when they also see clinical care or oral health providers within that setting. There are, under many value-based reimbursement models, and Medicare is a good example, newly introduced care coordination codes, which allow you to directly bill for time spent, not necessarily face-to-face with the patient, but actually working on that patient's case, working on their disease management, reviewing their chart, making phone calls, and the like. Other plans have offered well-visit billing opportunities, and even in high-deductible plans, this is often an opportunity for patients to seek care without having a significant or any out-of-pocket cost. So making sure that you're capitalizing on that opportunity for both your organization and your patient can be financially impactful. And lastly is the use of CPT-2 or other code sets. Not all value-based reimbursement methodologies will require additional CPT coding, but some will. And the CPT-2 code set, if you're not familiar, is the code set that actually tries to explain via a CPT code the health status of an individual. So it can actually help transmit what we would typically think of as some clinical indicators to plans. So making sure that your value-based models, if they require use of a special code set, that you understand how to apply that code set and basically how to embed that coding rules or those coding rules into your technology systems. Before I move forward, any questions on the revenue cycle? The next important process is about building management processes and systems. And this does get back to that idea and then we asked you folks about, and about a third of you said that you put some kind of formal work group together on this topic. But financial success under value-based reimbursement is heavily tied to your ability to produce clinical outcomes. And in a second, we're going to talk about actually planning appropriate clinical responses to various value-based reimbursement methodologies. But this is for probably for the first time where you've really had to put clinical leadership and financial leadership in the same room and focus on a set of data that likely hasn't been as much a part of the conversation before, and that's the total cost of care data. Again, if you recall, and we're going to go much deeper into the various payment methodologies when we talk through the case study, but as you recall, there are many types of value-based reimbursement models that tie directly to total cost of care. So having a leadership function that goes through this data on a regular basis, understands how to interpret it and use it, and then basically are committed to working to develop new approaches to care is really critical, and that's also the right group to be overseeing basically that implementation of a data sharing program, as well as a potential for a compensation model that's sensitive to value-based reimbursement. So, really it forces our financial leaders to be responsible for answering key questions like, what are the goals that we need to hit to be viable? If we're going to completely redesign our care model around these new reimbursement models, what are the most important drivers? We're going to talk about that in the case study in 2 weeks. How much can we spend on the infrastructure and to staff the functions that are necessary to deliver that? And what are the opportunities to reduce total cost of care? That's probably not how most safety net healthcare organization financial leaders have spent their time historically. It's probably been much more focused on the internal finances of the business, not the external finances of the population served. And that's an area, obviously, to look potentially for outside help and opinions. It also asks our clinical leaders to tackle questions like, what are the changes in practice, culture, compensation, and organization of our practices that are necessary to hit quality goals and improve total cost of care in order to make the overarching financial model work. And how do you create a clinical leadership function that aligns properly with the financial goals of the organization? We know that there are financial stresses and strains on organizations under fee-for-service models, and that doesn't go away. However, there are opportunities to rethink that, and it's a fundamentally different equation and formula. To get started, you need a couple of things, an organizational baseline for each contracted performance measure. So if you're going to be held accountable for either a clinical outcome or a financial outcome, you're going to want to determine what the gap in performance is, and then financially come to financial terms on what you can fund in terms of clinical interventions. And we're going to talk about quality improvement, something we're probably very familiar with, care coordination, something I think we're a little less concrete on, versus what we call targeted interventions. And targeted interventions I really think are something we're going to have to get very accustomed to because it's actually the most sensitive or the most impactful on some of the riskier payment models down the road. We're going to want monthly trends in those contracted performance measures to assure that we're making progress towards our goal, that we're trending essentially towards achievement of those goals, and that we have the ability as a leadership function to reprioritize our resources to maximize our financial returns. And hopefully the alignment of our reimbursement methodology with our personal goals or our organizational goals for our patients are highly aligned. So that we're, essentially maximizing our financial return when we're also doing the things that we want to do for our patients. We want to be able to look at provider or care team variation in each of the measures. So if the organization's held accountable for a measure, we need to break that down and understand if there's variation in performance, and take a hard look again between financial leadership and clinical leadership at what does clinical leadership need to do in terms of coaching and education, because that variation could in fact be the key to, reducing that variation could in fact be the key to a financially viable practice going forward. We want to look at total cost of care baseline data. We want to do initial planning when in models that are driven by total cost of care around the types of interventions that are going to be successful in driving success. And we'll talk about some of your peers throughout the country and what they've done. And also allows us to, really take a look at that forecasting and budgeting function. And we recommend month-over-month cost trending with comparison to previous periods. So you'll probably want to look not just at how did cost trends compare to last month, how did May of 2016 compare to May of 2015. There's some interesting anomalies in cost data that are very seasonal in nature, and I'm sure you're actually fairly familiar with this. If your organization gives flu shots, that would be a reason why we see a kind of a spike in the winter months as people are admitted to hospitals or using emergency rooms with flu-like symptoms or the like. So it's important that we have the ability, even if we're in the first year of a contract, we'd want to look at data, financial data, total cost of care data from before we were in that contract. So let's talk about those appropriate clinical programming and really the financial impact that it has on the business. We talked about kind of three different models: quality improvement versus risk adjustment versus very specific or targeted clinical interventions. And I think what you'll find is that there's kind of a spectrum here, that in the lower risk models, it is really more about broad-based quality improvement. In the higher risk models, we really have to get very specific about what it is we're going to be doing with these patients. Quality improvement, I think, again, we're fairly familiar with. This is a broad approach to analyzing data across the population, providing trending reports and ad hoc analyses, understanding where we stand as for a total population against the contracted measures in our contracts. And this, in theory, for pay-for-performance models that are basically tied to outcomes and outcomes alone will give us some early surveillance of whether we're going to be financially successful, where the gaps are, where we need to put additional resources if we wish to hit our pay-for-performance goals. So really important, probably the most important intervention in the basic pay-for-performance models, as well as in shared savings models that have quality measures associated with them. We pulled some numbers depending on part of the country, skill set, size of organization, quality data analysts, qualified data analysts, capable of developing and running this type of quality improvement initiative have a pretty wide range in salary. And one thing that we will note is in these models, certainly there's always a need to look at kind of, relative staffing levels based on size of population, but it's actually really driven more by the number of different systems that you're integrating data from, as well as the number of different contracts that you're supporting. If your data sources are good and clean and relatively stable, it really doesn't matter if there's 1,000 patients in them or 100,000 patients in them in terms of how these models scale. But what we're going to see is that in some of the more sophisticated models, that's very different. So I want to talk quickly about the concept of risk-adjusted care coordinators. This is, really where I think most organizations in shared savings all the way up through some of the highest risk models are focusing their efforts. And this is, really staff who are allocated to a specific population of patients with a goal of improving their health and assisting them in utilizing health resources in a more effective way. They have a very specific focus on reducing utilization patterns. And typically, it's best to have a minimum threshold for either historical cost or utilization of services before a care coordinator is assigned. And the reason for that is you want to basically, maximize the use of care coordinators for patients who are likely to experience a positive change versus those that may not have that complex of health needs. One of the challenges or variations here is you're going to find, again, variation in effectiveness. Not every care coordinator is going to be as effective at reaching patients as others, and so that's another avenue or area that you're going to have to evaluate. And as I mentioned, we see this concept of risk-adjusted care coordination in virtually the entire spectrum of value-based reimbursement once you get beyond basic pay for performance. So here's an example of a model. Again, we pulled some data which indicated, that roughly the median salary nationally was about $40,000, and that organizations were looking to assign patients to a care coordination model based on a risk-adjusted approach. So this is really pretty primitive. I don't want folks to leave here today saying this is a hard and fast rule. I think this, as it came from the advisory board, this staffing ratio tends to be skewed very highly towards private practice, largely insured populations, but it does give you a sense. They say about 5,000 commercially insured patients to one care coordinator if they're commercially insured, as low as 1,500 to 1 in a Medicaid population. But in our experience, that number is even, vastly too high. In fact, in various sub-Medicaid populations like the age-blind disabled or dual eligible, or if you're targeting or focusing explicitly on high utilizers, as low as 100 to 1 makes sense. We've seen even as low as 50 to 1, but 100 to 1 seems to be kind of the highest acuity level of the threshold. So here's how this might play out financially. Yeah, sure.
Hi, David Nemiroff from the Long Island FQHC. Just to talk about those numbers, we have care coordination through our health home. That's a project that New York State has with the federal government, and we get money for people who are chronically ill with two or more chronic conditions. And our ratios, and these are care managers who actually go to the person's home, so our ratios are closer to 1 to 35.
Okay.
Those other ones look like they're telephonic or, they're all computer-based because there's no way you're seeing 5,000 commercial patients.
That's right.
So that just sounds like in the office, really trying to understand and maybe calling people. But our folks go boots on the street and out in the world to see folks. And so the ratios are for around that salary, about 1 to 35, and it's funded through a direct payment. We bill directly to Medicaid for that service. It's based on the patient acuity.
Was that 2703? Do you know?
What do you mean 2703? I'm not sure.
2703 was the part of the Affordable Care Act that funded for Medicaid, the health home.
I'm not so sure. This was pre the Affordable Care Act. It was the health home where the feds were, and maybe be a part of it. It was the feds were offering states in the beginning of 9010 match.
Yeah.
So they were paying 90% of the dollars for it, but New York State kept the health home for care management because they saw the reduction in costs elsewhere.
Okay. So that would have been, it sounds like they threw down the federal match, the 90% federal match. Yeah, that was in fact something that was supported by the Affordable Care Act. I'm not sure if you might have had New York might have had that pre-Affordable Care Act, and then it was expanded to everyone.
Probably, yep.
I think it also highlights a point I want to make, which is the rest of the world. This data came from, again, the advisory board of a pretty respected healthcare strategy organization, just how much behind the eight ball we can be as safety net providers when these models are largely based on largely insured patient populations, largely employed patient populations, that it really doesn't get to a true understanding of some of the social acuity within our populations. This is a very, kind of standard grid that just kind of talks about how a population or how an organization like your organization might budget for or start to think about budgeting for staff. And in this, and this actually came out of some work we've done with the Accountable Community for Health model that really does look at social risk, social determinants of health, and then assigning them to navigators. And it very simply takes the the breakdown of about 15,000 patients and buckets them into low, medium, high, and very high risk populations, applies a ratio, a staffing ratio to these, and essentially predicts the total number of staff needed to meet these needs. In this particular model, we were assuming kind of a homogeneous blend of the various risk populations across care coordinators, rather than having some care coordinators that only work at the highest end of the spectrum. But that would be another approach, and that certainly sounds like the approach in Long Island was to really only focus on the very, very top of the risk and allow those care coordinators the time and flexibility to be in the home or what have you. This would be a less intensive model in this particular case, but the concept in terms of planning, financially planning, I think is the same. You've got to get to the ratio. You've got to look at the population and be able to put them into the appropriate buckets. You've got to ask for the money essentially to support those models based on the reality of the assigned or attributed population. But the third model is the one that really gets the most specific, and this is where organizations are taking very targeted responses to very specific subsets of the population. And I'm going to give you some examples in a second, but this is when the organization will take almost an organization-wide stance on certain clinical issues that have essentially a highly calculable return on investment. In these models, the ROI, the financial ROI, can actually be much more predictable. Is it always attainable? That's a different story, but much more predictable, as you'll see in a second. But it does require more intense planning, a more intense identification of the patient populations, and a commitment to implementation. It's a model that is very sensitive, certainly to episodic or global payments. So if those are something that interests you and you wanted to explore global or episodes of care payments, this is going to be kind of your world. We'll see that in a second. But also good for partial or full capitation, and may be appropriate in some shared savings models. So the example I like to use is, and this tends to be a kind of an elderly or Medicare example, but I think it really gets to the point of a specific intervention, is to provide remote monitoring of patient weight post-congestive heart failure discharge, which essentially allows the nursing team to quickly adjust either medication or lifestyle to ideally keep these patients from being readmitted. And when we look at just some kind of national average data, and we say, okay, within our population, we have about 500 annual first-time admissions with about a 25% readmission rate, pretty standard, and a cost of about $13,000 per readmission. Now we can actually start looking at interventions and say, okay, if we can just get that to a 15% readmission rate, that would create about $650,000 a year in savings. So then what is it that we need to do in this very targeted intervention? Well, we've got to rent we've got to pay for the cost of the in-home monitoring scales. We've got to pay essentially staff to provide the follow-up care and record the weights. That's going to drive more traffic to primary care because if the patients are showing a propensity towards factors that would lead to readmission, we actually want to get them in for a visit, so we have to account for that cost. And that does need to, kind of net out of out of that $650,000 in savings because it's real money that's still being applied and spent to the population. But here you can see that could generate essentially a $312,000 profit, just that reduction by about 10% of that congestive heart failure rate. This is an example. There's a lot of them out there, and so this is the model that really kind of requires the most creativity, the greatest level of brainstorming, the best understanding of how to interpret the incoming data, but also working very closely in partnership across the clinical and financial domains. Here's a couple of other examples that we've seen successfully applied in the safety net. One, is kind of the broad-based switching, coming to a clinical agreement that we're going to move patients from one drug to another biosimilar drug that is on formulary or has a lower cost profile. Obviously, that's not a decision that can be made from a purely financial standpoint. But when you look at the wide variation in the cost of these therapeutics, and you're under a total cost of care related contract, these are essential steps to evaluate. Nurse call lines, 24-hour access for hyperglycemia, helping to reduce emergency department visits, using telehealth-based psychiatrists to get patients admitted quickly to psychiatric beds. I think I've mentioned this example before, but the organization found that a lot of medical bed use and cost was really being driven by an inability to get patients effectively into the psychiatric bed that they need. So they created a targeted clinical intervention that led to cost savings, which led to higher compensation under a value-based reimbursement model. Any others that folks can think of that maybe they've applied in their own practices or are thinking about applying?
Andrew, this is Greg Vassie in New Hampshire. One thing that is being looked at is Project Echo.
Okay, yeah.
As a way to expand really the role of primary care in certain chronic diseases to eliminate the number of patient visits to specialty practices.
Yeah, absolutely. That's great. And I think it's actually probably not so early that we could start to see, there's probably some pretty good data emerging now about the cost effectiveness of that, correct?
Yes, I believe there is, coming out of Nevada and New Mexico.
Yep. Great example. Thank you. Okay, I'm going to keep us moving. I know Amanda's got a bunch of content for you folks as well. There's a lot of discussion, and unfortunately, we're not going to be able to spend the whole session talking about this. But new value-based models really do require us to explore new value-based compensation systems. And I think that when we talk about increasing of competition in healthcare, I think that this is going to be a critical avenue to explore. You're probably feeling pressure from larger health systems who are accumulating or growing their networks of providers, either through formal employment arrangements or the like. And a lot of this does get to how people get paid. And we realize that, finances are a motivator, but aren't always the greatest motivator. But organizations and providers are seeking shelter from the trend of value-based reimbursement in organizations that can essentially guarantee their ongoing compensation. And we need to take that trend seriously and look at finding ways of aligning the terms in our payer contracts to how we pay the people who provide care within our organizations. So I'm just going to provide some basic best practice or tips for how to deal with this. The first is, again, formally adopt an organization. Is there a question? Okay. Formally adopt a subgroup within your organization to oversee this. That can be that same group that's looking at the cost and quality issues in conjunction. It can be a different group. Look at deconstructing your value-based reimbursement models and identifying the types of behavior change that you need to drive the results necessary. The best compensation plans start with upside only, but phase in downtime over time, which is usually measured in years, not weeks, not months. Start with a small percentage of salary, grow that percentage over time. Consider variable compensation for all staff, not just physicians or not just physicians and other billable providers. But if the behavior change needs to occur across a broader team, how can you introduce some element of variable compensation across that team? And then probably the most important is having a clear and transparent process where providers can monitor essentially their own performance relative to their goals and the performance of their peers. The ability to implement these programs very heavily depends on our ability to provide transparency into how they're working. And lastly, a word on the implications on cash flow. All value-based reimbursement models have some inherent cash flow challenges, largely driven by the fact that performance must be evaluated before payments can be made, which means things have to have happened in order for us to determine what the payment should be. Total cost of care models require what's known as a claims run-out period. It's usually on the order of about 90 days. That's how long it takes for a payer to say, we feel confident that X percentage of, 99.6%, 99.9% of the claims will have been paid within 90 days. Now we can actually calculate how you performed. Attribution and eligibility reporting models are done periodically, which means that maybe quarterly, maybe monthly, you find out even which patients are assigned to you and for which you will be held accountable. And so that can be a challenge that leads to delays in payments. And eligibility determinations can be made conditionally and then reconciled later. That's not necessarily a new challenge. I think that's probably something we've all experienced in just our base payments. But this is where the rubber hits the road, is finding out 16, 18 months in that you had less patients maybe than you thought you did under that particular contract. Just a word of, kind of note, the Medicare ACO program doesn't make its first payment to successful ACOs until 18 months into the organization, into the model. You can't wait 18 months to implement some of these changes in your organization, otherwise there will be no payment. So these create cash flow challenges. In terms of strategies, we recommend that in a fee-for-service plus care coordination payment model, this is a good model for organizations to consider because it's an upside-only model with fairly guaranteed value-based payments to fund care coordination. And if you can get there as a starting point, then in fact, your financial challenge, your cash flow challenge is fairly limited. In prepayment models, there may be opportunities to seek a prepayment of savings, but that comes with the downside of having potential clawbacks. So you can fix the cash flow challenge, but you can't fix then having a potential downside risk challenge. Maintaining financial reserves is largely the predominant model. I think most organizations are going into this with an understanding that they just need to have some money in the bank to weather the investments necessary and, frankly, to cover themselves in the case that they aren't successful. But that doesn't necessarily always align with the reality. I think many of us have had to deal with just having the days cash on hand we want to have to support our operations. We don't necessarily have that additional reserve funding. So that brings us to the fourth strategy, which is to seek infrastructure partners. And we'll talk a little bit more about these, but infrastructure partners that can bring capital, can bring some of the infrastructure we need much more quickly, and may not necessarily require us to make as deep of an investment as we would if we tried to build this on our own. The downside to that, of course, being that they're going to be looking for a share of any gains. I am going to transition to Amanda, who's going to take you through kind of budgeting for some of this stuff. But I wanted to just quickly wrap up by saying this whole idea of managing under value-based is a particularly nascent field. It's pretty new, particularly in the safety net. And it is requiring us to think about a whole bunch of new investments and looking for opportunities to make these models work. I think requires us to be very aggressive in seeking ways to be directly compensated for the value-based work that we do. So whether that's through new billing codes for non-traditional types of care, like phone-based care, like going into the homes, or whether that's looking for a payment model that gives us the flexibility to fund those types of services, I think is really up to us and what we seek in the kind of contracts we look for. But we would suggest to you that making sure that you don't have money on the table that could be used to fund these activities in your existing revenue cycle is an important strategy, particularly those in states where Medicaid has expanded. It's been our experience, it's probably not true for everyone, but it's been our experience that has led to a series of good financial years or months, and that could be a source of investment for this, and that you're going to need a plan long-term for variable compensation and for dealing with the cash flow challenges associated with value-based reimbursement. Just a quick pause before I turn it back to Amanda and see if folks had any questions or any comments they want to make that we might be able to weave into our next two conversations. Okay, well then with that, Amanda, are you available to take us through the next set of content?
So what what I'm going to attempt to do in this section is provide some kind of budgeting benchmarks for some of the tools and infrastructure and staffing that that groups need to consider as they're moving down this road toward value-based reimbursement. I want to caveat this by saying that there are so many variables in terms of how internal infrastructure can be leveraged and paid for, whether you're able to use part of your contracting dollars. Oftentimes organizations have access to grant dollars, and as Andy mentioned, there are frequently opportunities to look at partnerships with either health systems or other types of service providers, or third-party administrators that can bring some of this infrastructure to bear. But what might come with that are some additional revenue sharing opportunities. So because the potential scenarios are infinite, seriously, it's pretty challenging to to boil it all down to, if you're going to do for P, this is what it's going to cost you, and this is the infrastructure that you need, and this is what you can expect. So what we've done is we've tried to kind of talk through what some of these costs are and give you basically a guidepost for what to expect in terms of costs, and then it's really, given what your unique situations are, I think the discussion that Andy just had is really important, because you need to look at it through the lens of what are your options for, variable compensation, and how might that affect your bottom line. You're going to have to test that out a little bit. Who are the potential infrastructure partners? And when you look at overall cost, what could potentially they be absorbing, but what are the trade-offs for that? So unfortunately, what we can't give you is kind of a magic formula to run all these things through, but we hope that, kind of how we've structured some of the categorization of these costs and these budgeting strategies helps you think about what might work best within your organization, given what you're contending with in your market. So as just kind of to recap where Andy was coming from, all value-based purchasing program and reimbursement programs are going to require some common elements. There's going to have to be some level of capital investment on the part of the provider. We certainly know that we're moving toward, higher touch, more, more systemic approaches to care coordination. And as Andy did a really good job in those slides that he pointed out, sort of different benchmarks for staffing ratios and the like. Again, depending on what populations you're working with and what incentive programs you have, that you're engaging with, that's going to be different. But we know that sort of centralized staffing for care coordination is going to be critical. And of course, analytics to improve your awareness and opportunities to prioritize your work, particularly around risk stratification and intervention design, are critical. The riskier models definitely require deeper skills, some of which are likely going to have to be resourced externally. Things like shared savings and capitation, as Andy mentioned, really require an understanding of total cost of care, and in many cases may require us to take on additional support for things like actuarial analysis or predictive analytics. We don't anticipate that those are skills that you guys are going to need on day one, and we don't anticipate that those are skills and costs that you're going to, that you're going to necessarily have in-house. And there's a lot of variation, and a lot of those things are dependent on what the population is, how big the population is, and kind of the timeliness of the data. So there's a lot of variables even within that. But as Andy indicated, what we do know is strong partnerships between financial leaders and clinical leaders are really integral in terms of making this transition, whether it's at an individual organization or if you guys are working together in some kind of health like some kind of provider network or some kind of health systems approach, it's going to be critical. Okay, so now what I want to do is just talk about kind of how we've categorized some of these priority investments. And you've heard Andy talk about some of this, but this breaks it down in a little bit more detail. When we think about what health centers, rural health centers, critical access hospitals, and other parts of the safety net really need to think about in terms of taking on value-based reimbursement models, there are really 5 key buckets that providers need to take a look at in terms of what type of infrastructure do they need to shore up. The first is around population health analytics tools. The second is around functioning and compatible health information exchange that will really inform the process of care management and data exchange. The yellow arrow really represents this sort of new bucket of skills that we need that relies on claims data analysis, actuarial services, and risk stratification. The fourth relates to patient engagement and activation strategies, really because patients play such an integral role in managing their own health care, and there are more and more requirements on to actively involve them. We need to be thinking about the types of tools and resources that we're going to need to do that. And then finally, care coordination staff. As the diagram kind of outlines, really, fundamentally, we're relying on our health IT systems to really help provide what I would call like the data muscle for some of this. Virtually all of our value-based reimbursement models are highly aligned with our ability to really manage our performance and track how we're doing. And so I think fundamentally we're making assumptions that the safety net understands that a high-functioning foundation for health IT is a critical component and is likely something that you have in place and you're still refining, but hopefully that doesn't represent a net new investment for you at this point. And then as Andy mentioned, this idea that you have management and leadership oversight, which includes providers and clinicians, and that folks are really focused on performance management. So any questions or key buckets, because again, you guys are dealing with real world examples. We're drawing from our experience, but are there sort of other key buckets of investment that you see that's kind of missing off this list? Okay, so what we're going to do is we're going to kind of walk through these a little bit, and we've tried to be as inclusive as we can about the various capacity that we see folks needing, as well as some of the approaches that safety net providers have taken in order to respond to some of these infrastructure needs. So when we talk about population health analytics tools, I mean, we've really seen a wide range in terms of what this can look like, and a lot of this will be dependent on what your existing clinical strategies are. But tools can really range from sort of basic manual processes to something that's highly automated and really dependent on, some level of health information exchange across provider sectors. Our typical guidance, obviously, is that population health tools should be implemented incrementally over time as those patient populations are prioritized. And this is an area where often if you're working together within some kind of a health system approach or health network approach, that it often makes sense to look at developing the capacity and purchasing the capacity to do this together. That's the other thing I wanted to mention is much of what we're going to talk about are not necessarily costs that need to be borne out by an individual provider practice. There will likely be ways for you to work with some of your peers that you're collaborating with on some of the population health strategies for these patients to really look at how you can create some economies of scale by working together in these areas. Obviously, population health and the analytics tools are highly dependent on health information exchange and IT. And, we think it's really important because we think folks get really focused on the kind of the price tag attached to new vendor tools and resources without thinking through kind of what those additional costs are going to be for staff training and workflow redesign. You might have to create, for example, new custom reports or new interfaces. And it's really important to keep that in mind as you're thinking about bringing new tools and processes to bear. So when you see our budget, you'll see, sort of examples of, what we would identify as potential training areas and why we should be thinking about proactively including that as part of our budgeting exercise. Organizations should make data on patients actionable by generating alerts to patients to seek appointments with their providers. So part of what the population health tools do is help support patient engagement activities that we're going to talk about in a minute. But we think that's a really critical component of sort of the panel management process that goes on that can really be fleshed out and accessed through these types of tools. And that ultimately not only the patients but the providers need to be able to use that information. Any questions on sort of how we've defined population health tools. And we know there's a lot of ways to manage your population health data. Some folks have tools that are potentially already built into their electronic health records. Others are employing a tool that sits on top of a larger, basically a reporting database where multiple providers are providing data if they're working across a systemic approach, so it's something like an accountable care organization. But really, what we want to challenge you to think about is how are you going to take this on, given the patient populations that you're thinking about working with now. Okay, so what we wanted to do was to kind of give you some guidance, and again, these are estimates, and based on what you have in terms of, or these are examples rather, in terms of what you know to be true about the approaches that you're being presented with in your market, it might look a little different. But we've pretty much, for each of these 5 areas of infrastructure investment, we've broken it out really for, tools and resources that you're going to need for fee-for-service and care coordination, or fee-for-service and shared savings, versus the riskier models like global payments and partial and full capitation. So for fee-for-service and coordination, and for fee-for-service and shared savings, you're going to need to have, some health IT staff and some basic care coordinators. How many care coordinators you need and at what level, that will depend on who your patient population is and what your structural priorities are for those patients. You'll also need to have, a functioning EHR that has good data in it, and the ability to do some basic patient empanelment functions so that the care coordination can be properly stratified and the care managers and the provider teams really know who the patients are that they're working with regard to these particular activities. And then you're likely to need some workflow redesign, and particularly around those empaneled patients. Typical costs for these types of population health investments include things around staffing, again, any kind of annualized EHR costs that you might have, and then some workflow and team training. When you get to global payments and partial and full capitation, it starts to get a little bit more complex. You'll need everything that's noted above, plus you're likely to need some infrastructure for health information exchange, if not for all your patients, at least for the ones that are targeted within the contracts or the initiatives that you're looking to engage around. You will, particularly for global payments and full capitation, want to have access to some advanced population health analytics and some predictive modeling that gets pulled out of those population health tools and allows you really to begin to look at what's really going on with access and utilization, and might require you, if you don't have that capacity in-house, to be looking at outsourcing it. And then, as Andy mentioned earlier, the use of patient monitoring tools, resources, or practices are critical. So the costs, again, everything noted above, and then this is really where you see, some cost involved in building out some interfaces, whether that's directly with your EHR and the HIE, or indirectly through some kind of centralized data aggregator, and some kind of a connection between the population health analytics tool and what your providers are going to need at the individual practice level. And again, advanced analytics staff capacity and utilized cost for patient monitoring tools. Any questions on that? Okay. Health information exchange. I know many of us are dealing with what this means in our specific health ecosystems, and I think we've all experienced sort of different levels of success and challenge around the HIE conundrum. But again, much like the population health management tools, this really occurs on a continuum based on kind of what the needs are of your specific patient population and existing relationships and exchange opportunities might have available to you in order to really provide, important data back into their planning and performance management. So these can be very manual processes, or it can be highly sophisticated with, fancy interfaces that are built across a health system. The type of data that move across these exchanges also can vary widely, and that's part of why it gets really hard to estimate some of the costs for some of these things, because your health information exchange partners may have prioritized different areas of exchange, and it's hard for us to know during an exercise like this to really identify kind of what the costs are. But typically what we see is, pharmacy, lab, admit, discharge, and transfer data, referrals, and, basic provider communications. One of the important pieces about HIE is really making sure that there's a strong vision, both, kind of at the community level across all the stakeholders, and that providers really buy into making sure that their data is as good as it can be when it's going into the system, and that they're actively, the word I'm looking for, really engaged in using the data that the HIE has available. So clinician and provider leadership is important here. In particular, if there are challenges with the way that the data within the HIE is moving around. Over time, depending on how, again, this is highly dependent on your health ecosystem, you may even be in a situation where your practices or providers are engaged with multiple HIEs. You might have one for a particular health system and then one for another health system. Maybe your health information planning has been more cohesive and you don't have that contingent, but we do that contingency, but we do see that happen frequently. We also want to underscore that a part of what has to happen when you start to thinking about infrastructure and budgeting is this idea that we have to open up some capacity and budget for issues related to data governance. This is an area where we spend a heck of a lot of time working with groups that are really looking to engage across, a broader part of the system. And we want to make sure that when you think about HIE, you just don't think about it in terms of the technology and the training for your providers, but that you're also thinking about, okay, what is sort of the maintenance of effort and any associated costs that might come with putting an effective governance model in place. And we'll talk a little bit, about, when we get to the more specific exercise on the actual, dollars and cents of it all. But this is potentially consultative services to help develop things like, HIPAA agreements and business associate agreements. It's potentially, legal services to help you, both protect yourself but also gain access to the type of data that you'll need to effectively meet the needs of your population. So any questions on kind of the definition or the scope of health information exchange as we've sort of identified it here?
This is Marnie Holder from Piedmont Health. I was just wondering if there's any tremendous success stories with HIE across the country in terms of states that have, with the more regional HIE, like exemplar?
I mean, the short answer is kind of. It really, I think there's been more success on a regional level, particularly where you have a health system or a hospital system that's really taken the lead on really engaging the providers within the community. I think this is and I'm sure that I could just hear, Samantha and Andy's collective eyes roll to the back of their head, because, this is a huge challenge for folks. We have probably in about 3 states where we're working, it's total dysfunction around this issue. And I think, again, this is where costs are. There's a lot of costs here. We're not suggesting you should bear them all. And we certainly have had the experience where, millions of dollars have been funneled into these systems that are sort of still limping along at best. So Again, I think we're kind of trying to present things from sort of the ideal state, framework. But yeah, absolutely. I mean, it's likely that more manual processes are probably going to be what you have in place if your your regional or your statewide HIE isn't fully up to the task that where you need them to be. I don't know, Andy, if you want to add, or Sam, if you want to add anything to that. I wish we had really, really stellar examples of it, but
why don't we make a point, Amanda, in next week's intro, or in 2 weeks in the intro to talk about a couple of models that we've seen working.
Okay, we can do that.
Thank you.
It's a good question, though, because it's one that creates a lot of anxiety, because providers and practices don't want to be hit down the road with expenses and costs and infrastructure build-out for things that, were essentially promised to them as part of, the development and the planning process. And it's a huge area of contention. So health information exchange, again, similar to how we did the last one, the lower risk areas of reimbursement. Again, you're likely to have things that are much more manual in process, or potentially, some exchange going on that is integrated into care planning, but there's probably staff in the middle that are helping to gather that information and make sure that it's properly aligned with the systems that you need to do the work of managing those populations. We think it's important to have, that basic governance process in place across the stakeholder group right from the beginning. So even in an area where you're just looking at basic data sharing, we think that's likely to be an area of cost that you're going to need to think about considering. Again, staffing and workflow team training are going to be important. When you start to get into the more complex models of payment, obviously everything above, and then more advanced models of HIE governance, some centralized staff to really assist with HIE coordination and reporting. And really this is where you start to see dollars getting funneled for things like technical build-out and reporting capacity, and potentially some real legal expenses associated with that. The third area is one that creates a lot of anxiety for the safety net, because this is an area where our depth of experience doesn't go as far as maybe in some of the other areas. This is an area around sort of claims data analysis and risk and actuarial services that we see a lot of groups, whether they're working independently as practices or working as part of a network or systems approach, really look to third-party support for this, because these are not typically skills and infrastructure that we have in place that we can build off of. But needless to say, again, tools are going to be range from the very basic manual processes to things that are highly automated. A lot of this will have to do with how sophisticated your integration is with the payers and the health systems that you're working with. And I think that's an important point, that this is often a set of skills and capacity that those payers can bring to the table, with all, and they may be able to help support this for you, but still at the end of the day, you're going to have some working capacity within your organizations or your networks to be able to use what they do give you, even if they're really doing the muscle to run the reports for you. You're going to be wanting to think about new relationships or expanding your relationships with payers so that you can make sure you're having those conversations, and that you're looking at the type of data and systems that you need to put in place for that. As Andy mentioned, this is often a place where third parties get involved. And, it's really hard for us to give you an estimate on what actuarial expenses cost. I think the kind of rule of thumb we use is think of it almost on par as what you would do with legal expenses. So somewhere between $250 and $400 an hour. And again, it's going to vary based on how complex your data sets are and what you're looking to accomplish with that, and how big they are. And so, like I mentioned, again, payers and health systems will often have resources that you can leverage. For Fee-for-service and care coordination, you may or may not need to have access to claims data, but it would really be helpful to be able to infuse part of your process with some of that utilization data so you can be thinking about how to target some interventions for the populations that you're receiving care coordination or any kind of pay for performance on that. Again, what that's going to do is really give your care coordinators just better information and better data to be able to really risk stratify those patients. Some of the costs that are associated here relate to things that include, staffing and some data systems and analysis and some team training on what we do when we get this utilization. What do we do with the data once we get it? When you get into the more complex models like global payments and full capitation, this is where you're going to really need support in understanding true risk stratification and actuarial capacity. This is where you start to see things like advanced data analytics and predictive analytics tools. And we don't necessarily assume that those are things that you guys have in place. And so it's extremely important when you look at global payments and full capitation to be able to do some level of predictive analysis on those patient populations. And again, we think that's likely going to be something that you're going to have to outsource if you don't have access to it already. In terms of patient engagement, this is really, an area where safety net providers have had a lot of experience. Many of you are actively involved in the communities in which you are providing service. But under these new value-based models of reimbursement, we really need to be looking at really extending out what our engagement and activation efforts look like. So, first and foremost, meaningful engagement begins with really understanding who your patients are and what their needs are. And, there's a whole learning collaborative that we're going to be doing after the new year just around patient attribution and activation because it's such an important skill set. You get a list of who your patients are as far as the payer is concerned. You need to really be thinking about kind of what do I need to be doing with this list of patients, whether I've seen them or not. So really having access to, information about who they are, how you're going to engage them, and having some sort of central resources in the middle that can help to sort of parse that out. This is really going to include tools and workflows to think about engaging patients in communication that will range both from low to high touch. I know we're familiar with a lot of these different models, and it could be anything from, patient mailings to, phone check-ins to home visitations. It's also important that there may need to be some redesign of your care planning to include, different strategies like remote monitoring or telehealth, but also you might need to look at just, what do you have in your patient self-care, aspects of your care planning. Do we need to do some specific training for providers? Do we need to, think about things like health literacy, for the patients? Like, what is it that we need to really get them involved, and what types of resources might we need to direct, to help support those efforts? This really does go beyond, sort of our typical patient satisfaction and looks at tools like the CAP survey. Regardless of how you feel about the CAP survey and how much it costs to administer it, it is often used with many of these programs that are funded by Medicaid and Medicare to really, to get a sense of what's going on around patient engagement. And so really thinking about patient experience and engagement, both from a workflow perspective, but also in terms of how we're going to gather good data that helps us understand better what's going on with these patients. So again, we probably can have processes that, build off what we've done for things like care coordination and shared savings, where you have care coordination staff that are really using those patient and panel lists to directly do some outreach to high-risk patients. Again, embedding into our care plan some specific things for patients to respond to, and then some kind of patient satisfaction survey. Again, your costs there are going to be around staffing and training and EHR reporting costs, and if there are any costs associated with the collection and the analysis of the surveys themselves. Once you get into global payments and the capitation models, what you have are really, the need to look at how you use technology different in order to engage those patients. And again, I think some of you are already piloting things like remote monitoring and patient portals, but those are definitely infrastructure tools that a lot of groups are using. And then in addition, really being able to drill into those utilization reports to understand who those patients are and how that's going to impact our outreach and engagement strategies for them. Care coordination staff, we talked a lot earlier, Andy talked a lot earlier in the session about, what those models might be and what some of the variations are that that we need to take into account, and how, how you're going to staff your care models and what that looks like are, it's important to kind of keep in mind as to what your contracts are going to expect of you, and where there might be grant funding to help support some of that work. So again, this is pretty straightforward. We understand this. And again, it doesn't look dramatically different, except that under global and capitated models, you might be doing, more intensive case management of certain patient populations that are going to be highly driven on what your risk models tell you might need. You're likely in those models to be working with a very high number of patients, and you'll see that when we look at the actual budget portion. And that's why it's important to think about how some of these resources might, be the cost of some of those resources, whether it's technology or staffing infrastructure, might be brought to bear across, a group of providers. So where does the investment come from? We talk a little bit in terms of how important it is for safety net organizations to start thinking about organizational reserves. So if you do have increased revenue from Medicaid expansion, what is the right use of that, that increased, that net increase now? Is it, there are lots of ways for us to think about, directing those revenue increases, and we think as we are going to be presented with more riskier models down the road and in the foreseeable future, it is important for you guys to start having conversations about reserves sooner rather than later. Obviously, payer contracts will provide opportunities for you, particularly in the form of, incentive or care coordination dollars. Many of you may have access to grant funding that can help support some of these infrastructure costs that may not support ongoing costs. So again, it's important to think about how you build that infrastructure with those types of dollars, but really leverage it so that in the out years, you've got an infrastructure in place that allows you to maximize your contracting revenue as much as possible. Again, MSO fees paid to networks of providers. Again, there are lots of opportunities to work with partners, on developing this infrastructure, but that will come with it a set of costs, that you'll have to take into account in your overall budgeting. Foundations and other partners might be looking to help support some of this, and in some situations, you're able to borrow against future revenues. I think in previous sections we talk, and we know we have at least one of the cohort members who's functioning under the ACO investment model, which is essentially you get upfront payments to build infrastructure so that you have the ability to put the kind of practices into place to pull the funding down later. And those are options also not super frequently presented, but when they are, we think it's important that you take them seriously and you really think about how you're going to budget to help support your ability to pull down future revenue later. And then finally, working with an infrastructure partner, and we've talked about that many times. So now I'm going to do a quick overview of what a budget could look like for a single organization, a single individual practice that's got 1,500 patients, that it's receiving a fee-for-service payment plus some care coordination and pay-for-performance dollars. And again, remember, these are just placeholder amounts, and your revenue or cost offsets might be different depending on what type of infrastructure and grant resources and partnership arrangements you have. But under this model, this is actually incorrect. But under, I'll make the correction to this slide. The first one really is a single nurse manager for $75,000, not $375. That's on the next slide. Staff training dollars, particularly around care coordination and empanelment. Part of an FTE of a data staff person within your organization to help with performance management reporting. Staff training or consultant resources to assist with some basic risk stratification on your patient population. A patient outreach coordinator or navigator to help the nurse care manager with things like callbacks and other types of support. It might be important with this patient population, depending on what the intervention model is, to make sure that there's some patient education materials. And then some administration of in-house patient experience survey for this particular patient population. In this example, we have that total cost, if you assume that the top is 1 FTE and not 5 FTEs, the total cost of $112,000. And just in terms of some of the cost offsets, we've made a pretty conservative PMPM for this patient population, which would free up about $54,000 to help support some of these activities. And then in addition, we just had an estimated of earned revenue off the P4P incentives at about $60,000. So again, not knowing what those particular P4Ps are, we're just trying to sort of be directionally showing you the types of revenue sources or cost offsets to help support that. This sort of basic P4P model with a relatively small patient population of about 1,500. Any questions on that? Okay. Here's a more complex model. This represents a fully capitated model with about 25,000 patients. It's not anticipated that you would have the ability to manage a patient population panel of this size as an individual practice. So within the scope of this particular budget, we're making the assumption that you're working together with other providers, either through some kind of a network construct like an IPA or an ACO, or some kind of health system approach. So the numbers are much bigger, and there's a lot more infrastructure. But again, remember, this budget's really presented network-wide, not for an individual practice. So here we go. We've got, in this case, we've got about 15 nurse care managers spread across the participating organizations for a cost of about $1.1 million. We think it's really going to be important to have staff training in all of the areas that are noted there. We've applied to this model an annualized cost of a population health software tool. We've also included a third-party administrator to assist this network with things like claims integration and billing support and potentially administrative services. So you see the line item, set up there. Under this model, it's going to be important that there are functioning health information exchange interfaces, and we've made some assumptions about what it might cost to get 10 provider practices properly aligned with that. Legal and consultation services to support the data governance development, data staff to help with this advanced analytics capacity, actuarial support, and again, that's a placeholder just depending on, which could be highly variable depending on what the needs of the patient, what the patient population was. And then you just sort of see, kind of what this looks like. The thing that we want to draw your attention to really are in the last two items, which is this takes into account that part of the cost of implementing this includes beginning to build some network reserves as well as setting aside some money to do gain sharing with providers. This is intended to align with some of those discussions that Andy was having earlier around the new compensation models. So making sure that out of the gate, you're putting into your budget some placeholders for what you anticipate you would be setting aside for provider incentive payments, and network reserves. And then this is, this takes into account, and we did actually a calculation on sort of the average cost of a Medicaid patient and divided that annualized cost of about $3,000 by 12. And that's how we got, we figured out some of this. These aren't just made up numbers of the $20 PMPM. So roughly you would have the ability then under this capitated model to pull in, $15 million for your 25,000 patients, but you have all these costs associated with them. And, and this sort of gives you a directional idea about how those things might shake out. So any questions on that?
I had a question. It's David from the Long Island FQHC. In this model and in both models, where is stuff like, your rent and all that other stuff built in? This is really just for staffing and all the things related to value-based payment?
I'm sorry, where is the stuff for what?
The cost
missed that. You were cutting out a little.
OTPS. Like other than personal services, rent and malpractice and all that stuff built into that.
Yeah, that would just be built into, your staffing and infrastructure costs. So we're making assumptions that these are sort of additive costs, but you would definitely want to, probably come up with some kind of an administrative multiplier. Typically what we see is usually about 20%.
Okay.
Yeah. Okay. So really quickly, and I promise that we can get through this relatively fast. Part of what you guys have in today's materials are a handout. It should just be a 2-page handout for the case study discussion that we're going to have next week. So our goal really is to help us think about kind of the discussions that we've had over these sort of last 4 content areas around how to think about all the financial dynamics and management and budgeting infrastructure things that you might need to put into place to really engage with some of these, with one of these or more of these payment models. So what we're going to be doing is we're going to be assigning your particular cohort a value-based reimbursement model, and you're going to be reviewing that and responding to a series of questions that are, it's not even really a case study, it just sort of talks about what those models are, and then you would answer those questions as it relates to your organization trying to deal with that particular payment model. So next week's session, as Andy mentioned, is highly interactive. Where you really need to come prepared because we have multiple groups talking about each of the, I think all but one of the payment models is a repeat, but we really want to make sure that you guys have taken time to think about the impact that it would have on your individual practice or the group that you're working with as you try to take this on. So the case study questions that you'll be reviewing and should come prepared to discuss next time are enumerated on the screen, and and you'll have in your case study materials, each of the 5 reimbursement models. So we took a pass at putting this together for you guys in terms of the of which one of those models you'll be looking at, and again, you'll see them described in your case study. So we tried as best as we could to try to align them with some of the activities and issues we think you might be contending with, but it's not always a perfect match. So again, just do your best to kind of go back through these questions as a group, responding to them as it relates to your particular payment model. And we're literally going to be going payment model. We'll probably do a little bit of a refresher on what each of those models are, but really the focus is really to kind of talk about what are some of the challenges and risks that these new models bring to you, what do you feel ready to do, where you feel you still have gaps, and really to get a sense of what some of your peers are concerned with as they're looking at these models as well. So that's it for today. Andy or Sam, or AJ, I don't know if you guys have anything else you want to add, or we just appreciate you guys taking a little time, between now and the next 2 weeks to kind of go through those questions and respond to the case study. We're really looking forward to it, and we know that every practice and every kind of region has its own dynamics that it's contending with. So we anticipate that while there will be some common themes, there may be things that are unique to your organization or your network that are probably going to be pretty important for your for your peers to hear. So anything else?
That's it, Amanda.
Okay. Great, guys. Thanks. And we'll talk in 2 weeks.
Thank you.